All right, everybody. It's Peter here again. Today we're going to talk about endocrine and hematologic emergencies, which is chapter 19 of your textbook. A couple things about what the endocrine system is. It's the system that influences every cell, organ, and bodily function. It's actually a very often ignored system, but it's the endocrine system that basically helps your body maintain homeostasis. So you eat something with a lot of sugar in it, it releases insulin to reduce the sugar in your blood. If you haven't eaten all day, it releases glucagon, which will release the stored sugar to back in your blood, so you maintain normal blood sugar. If you get too hot, it's the endocrine system that helps control your sweating. If you're getting too cold, the endocrine system controls your shivering. So it's a very important system, not very glamorous, but it's actually one that's extremely important to understand how the body functions. All right, so the anatomy, physiology, real basic. Basically, the endocrine system is made up of glands. A gland is any structure that secretes a hormone. There are multiple endocrine glands. You have your thyroid gland, you have your pituitary glands, your ovaries, your testicles, your adrenal glands. Those are all glands that make up the endocrine system. Endocrine system disorders are caused by a communication issue within that gland or in the sensors that report to that gland. Big one that we're going to deal with would be glucose metabolism. The brain loves oxygen, loves sugar. It's a huge user of both of those items. If you don't have enough oxygen, you have an altered mental status, you're hypoxic. If you don't have enough sugar, you have an altered mental status because the fuel needed to keep your brain running, functioning normally isn't there. And you need insulin, which is released by the pancreas for glucose to enter cells. So if you think of glucose as a gatekeeper, when you have sugar and you have a diabetic and they eat food, the sugar stays in the blood. But until you have that insulin molecule attaching to that glucose molecule to take it into the cells are surrounded by sugar molecules, but that sugar, which is the fuel for the cells, can't enter the cell where it's going to be used by the mitochondria to have that cell function. It's a very simple way of understanding what's going on with diabetes. All right, so we have a couple different types of diabetes. Diabetes mellitus is just, you see the abbreviation DM, we'll just refer to it as diabetes. It basically, as I just mentioned, it's a disease in which the body is unable to use glucose for fuel. Without treatment, your blood sugars go high. Standard range for your blood sugar when we check a blood sugar is between 60 and 120. Some books and some protocols are going to, they want the sugar to be between 70 and 110. Having too high of a blood sugar or too low of the blood sugar is life-threatening, but low blood sugar is going to kill you very quickly. High blood sugar, it usually takes several days before it causes any significant medical problems. But a lifetime of running high blood sugar is what's going to cause kidney disease, blindness, cardiovascular disease, and stuff like that. So again, what we need to know is hyperglycemia is high blood sugars, low blood sugar is hypoglycemia, and both of these can occur in type 1 and type 2 diabetics. All hypoglycemic patients need to be treated quickly. Hopefully they're still conscious enough to take oral glucose. If not, there's medication like glucagon that can be given to the patient. There is a third type of diabetes. It is gestational diabetes. It occurs in some women when they're pregnant, and that diabetes tends to resolve itself once the female delivers the baby, anywhere up to a year after the birth. So diabetes type 1 is an autoimmune disease. This is also known as juvenile onset diabetes. This is not a disease that's related to lifestyle choice. Basically, the pancreas stops producing insulin. Usually you'll see, usually in males, usually you see it sometime between like the ages of 7 to 12 years old. The child is feeling run down, lethargic, weak. Parents think the child's sick. Finally, the kid's not getting any better, or even worse, they end up losing consciousness. They get taken to the hospital. They do a sugar check. They realize that the child has extremely high blood sugar, and they're basically diagnosed with type 1 diabetes. As of right now, there is no cure for type 1 diabetes. This person is going to be on insulin their entire life. They have to do insulin. Sometimes they get insulin pumps that you'll see on their belts uh, that's attached to their abdomen with 2 probes. They're going to be checking their blood sugar on a regular basis. All right, some signs of type 1 diabetes is polyuria, which is they're urinating a lot, polydipsia, they're very thirsty, polyphagia, they're always eating, they're not gaining weight, and they're always tired. So basically, they're getting all the sugar in there. Their body wants them to eat more and more, but that fuel is never getting to where it needs to go because the insulin won't take the sugar to the cell or inside the cell. The body detects high blood sugar levels, so it wants to drink a lot. So you get that thirst all the time. So you're always drinking, start urinating a lot, getting rid of the extra sugar, but your body is starving from sugar at the same time. So you look at this person, type 1 diabetes, you can have kidney issues with anyone with high blood sugar. Someone who has type 1 or type 2, if they don't take care of their sugar levels, they're going to have high levels of sugar in their blood. The kidneys basically get damaged by trying to filtrate all this glucose. It gets into their urine also. So their urine can be tested for sugar levels, which is how they did it back in the day. And again, the body is just starving for sugar. It burns the fat for the sugar that's stored in the fat. You produce ketones, and the kidneys, as we say here, can't maintain this acid-base balance. Someone who goes unconscious due to low blood sugar has something called Kussmaul respiration, which is a really loud, snoring, rhythmic respiration. If you continue to burn ketones, you go into DKA, which is diabetic ketoacidosis. That's basically you're going now into a coma, and you can have seizures, results in death. So when you have someone with low blood or high blood sugar, you're looking at this DKA issue. Our glucometers, depending on which one you're looking at, can measure up to 600, 650. Sometimes you just get high if it's outside of that range. So you're thinking severe hyperglycemia, and that patient, if they're altered or unconscious, is going into DKA. When in doubt, we always treat any diabetic who has an altered mental status as hypoglycemic. So if you have someone with hyperglycemia and you give them some more sugar, you're not going to really affect their outcome if you take their sugar from 550 to 600. But if you have someone who's actually acting altered and their sugar is 60 and you don't intervene straight away and their sugar drops to 50, they may lose consciousness. And at that point, you're not going to be able to provide them oral glucose. And the change in patient status from sick to very sick is much more rapid with hypoglycemia. So if you don't have a glucometer, when in doubt, we treat all altered mental status, diabetic possible patients with if they have low blood sugar, so we give them that oral glucose. And in class, we'll talk about how to give oral glucose if they have an altered mental status, because obviously they have issues with gag reflex and we can't have them drinking a soda if they have that altered mental status. So with your type 2, this is what we commonly refer to as adult onset diabetes. Nowadays, we do see teenagers who end up developing type 2 diabetes. It is mostly a lifestyle choice disease. A simple way of looking at this is your body, due to the diet of high sugar, high fat, has developed a resistance to its own insulin. So this diabetes, while we don't like to call it a cure, sometimes if you change your lifestyle, reduce your risk factors, you may be able to get off of medicine. Someone with type 2 diabetes doesn't necessarily need insulin. If someone with type 2 needs insulin, they're pretty far along and they're probably doing a poor job managing their type 2 diabetes. Not in all cases, but in many cases. Most type 2 diabetics can treat their diabetes with oral medications such as metformin or glyburide. And what these two medicines do is reduce the sensitivity of the body's cell, so it allows them to uptake that insulin easier, because the body is still making insulin in most cases of type 2. It's just the insulin cannot get into the cells. The body is basically resistant to that insulin. So one of the things about the medication, and even if you're taking insulin, if you don't eat and you take the medicine, it can send you into hypoglycemic shock. So you'll get elderly, for example, they wake up, they take their morning insulin pills, and then they forget to eat. And now you have someone who took a medicine that lowers insulin, or sorry, that increases insulin secretion, but they didn't eat to counteract that insulin, and now they're hypoglycemic. You also get, during the cold and flu season, people are so used to just taking their medicine, especially the elderly. They have their little pill container, and they take their morning pill, take their afternoon pill, etc. So they get up, take their morning medication, which contains their glyburide or their metformin, and then they get nauseous, so they throw up. So they've already absorbed their medicine, which is going to lower their blood sugar, but now they can't keep breakfast down. And next thing you know, you have someone who's having a diabetic emergency related to low blood sugar. There's also injectable medicine, glucagon, and there's some other medicines out there related to insulin that are available on the market now. But what glucagon is used for, if someone goes into hypoglycemic shock, so they're unconscious due to low blood sugar, you can inject them with glucagon, and glucagon is the hormone that will release any stored sugar. So we'll release all the stored sugar in the body from the liver, hopefully enough to increase that person's blood sugar so they wake up and then can either eat and drink some sweet fluids to bring their sugar up back to a normal level. And usually though, once you give them glucagon, if it doesn't work the first time, it's not going to work the second time because there might not be any stored sugar left to be released at that point. So again, glucagon is the emergency treatment for low blood sugar if the person is unconscious, unresponsive. We carry that as paramedics. Our first thing that we treat someone with low blood sugar is usually an IV with D10. If we can't get an IV stick, because many diabetics have very poor vasculature and tend to be overweight, we're going to go with that glucagon injection. So, and if you have family members that are type 1 diabetics, they should have this glucagon injector kit. There's a new one on the market now that's a nasal spray. You see a commercial for it right now on TV. So type 2 diabetes, unless they end up with some medical issues related to high blood sugar, it's usually found during your annual physical. They check blood sugars for the annual blood work, and they see that their sugar is high. This is where you have these patients that when you ask about their blood sugar, and you're like, oh, I run 220, but that's okay, that's my normal. If 220 is your normal sugar, you're causing yourself problems with your cardiovascular system, with your kidney system, your kidneys and everything else. There's some signs and symptoms of type 2, which are similar to type 1. You're always thirsty, you're always hungry, weight gain, fatigue, frequent urination, but you also get these skin infections, neuropathy of the feet. You start getting nerve damage in your feet. So a real basic way to diagnose type 2 diabetes or type 1 diabetes, but especially type 2, is you do a finger stick first thing in the morning. And if your finger stick's over 120 after fasting for 8 to 10 hours, you're a type 2 diabetic. So our symptomatic hyperglycemia. All right, this occurs when the glucose levels are high. And I've been talking about this in the previous slides here too. So your patient presents with an altered mental status due to ketoacidosis related to type 1 or type 2. We have something called non-ketonic hypermuscular state of dehydration. So it's, I believe it's in the book, NKH, not positive, sorry, I'll have to double check that in the book. And again, they're dehydrated because they're always urinating. Their body is just trying to get rid of this sugar. So here, I'm sorry, the abbreviation here, HHNS. All right, we're going to treat these the same in the field as EMTs. There's not much you can do with this if someone has super high blood sugar. Even if they're conscious wagon oriented, we don't want to give these people fluid by mouth. We don't want them to aspirate, have more nausea or vomiting. For a medic, what we do start an IV and we run normal saline. Basically what we're doing prior to getting them to the hospital is we're going to try to dilute that blood sugar by adding fluid to their circulatory system. Ultimately, this person's going to need insulin at the hospital. So as I just said, with the high blood sugar, very thirsty. That's your body's homeostasis, trying to get rid of this sugar, high levels of sugar in its blood that it detects. But you just start urinating out your electrolytes, and you ultimately become unconscious. You have this whole seizure, coma, death event that happens due to severe hydration and your homeostasis being out of whack. All right, so you have your symptomatic hypoglycemia. The more common type of diabetics emergencies that we deal with are going to be that hypoglycemia. Hypoglycemia can come on very quickly. Hyperglycemia tends to be more of a slow onset, several days of medical issues, not eating right, being sick, not taking your medicine. They ran out of their metformin or some other medication that they take, and their sugar is now through the roof. Hypoglycemia, this is as I mentioned earlier, they took their medicine in the morning and then they forgot to eat. They took their medicine in the morning and they got nauseous and threw up, so they couldn't keep food down. They went out and did yard work, and they burned off more sugar and they didn't replace it, and so they go hypoglycemic. Again, the brain is the biggest user of glucose, so as soon as that glucose level goes down, you end up with that altered mental status. It can be aggressive, it can be aggression, it can appear as if they're on drugs, it can appear if they're drunk, if they can have a seizure, coma, and die. It unfortunately is not uncommon for someone who gets pulled over for drunk driving or is in an accident and it appears the person's intoxicated. They would be taken to the jail for DUI and they end up dying, and it ends up they weren't drunk, but they were actually having a diabetic emergency. So police like to make sure that anyone who has some sort of altered mental status, that they get some vitals checks, get a blood sugar, make sure it doesn't appear to be any sort of medical issue. When in doubt, we always want to treat anyone with that altered mental status with sugar. As I mentioned, you can't mention that enough. All right. Hypoglycemia can be quickly reversed by giving them food, giving them sugar. This is someone that you could get to their home and treat them, and they're severely altered. And this is one that you're going to stay and play. You know, if they're able to swallow food and you get them some oral glucose, get some orange juice, squirt the oral glucose into that orange juice to make it even more sweet, have them drink soda. They wake up a little bit more, get them a peanut butter and jelly sandwich of some sort. You know, we've sat there on scene and we've treated these people by making them lunch, and we get their mental status back and their sugar is now in normal range, and you can assure that they're going to have food. They don't need to go to the hospital. You fix their sugar issue. Now, if there's some new diabetic issue that's come up, you might want to have them go to the hospital for eval. But for the most cases, these patients that have altered mental status due to hypoglycemia, they have diabetic issues and they know why they went low. They didn't get home in time to get their sugar pill or to get their meal, or they did something that caused them to go into hypoglycemic shock. So it's usually very easy to reverse, and it's something that we do refusals on all the time now. As long as we can get their sugar up to the normal range. If we do an IV into them, the sugar goes up pretty quickly. If you're doing it orally through food and oral glucose, it usually takes about 45 minutes for them to get that sugar to the normal range, but it's still 45 minutes on scene is still shorter than getting them into the ambulance, driving them to the hospital, turning them over to the hospital, doing all that paperwork, and then getting back in service. So it's worth waiting and doing that treat and release on the scene with someone who's hypoglycemic. When we have these patients, again, BSI scene safety, you guys have gotten used to this routine of how the slideshow presentation goes, right? They provide you the information, and then we go through this, either the trauma or the medical scene size up. The things that we're going to look specifically for someone with diabetics, be aware many diabetics, at least all type 1s, are going to need insulin injection. So you have syringes, and people just leave syringes on their tables and the couch cushions. So you don't want to just sit down anywhere. You want to look for these used syringes. If they're unconscious, you look for those medical alert bracelets, check the refrigerator. Insulin is kept in the refrigerator. Always consider trauma. Just remember that when in doubt, everyone who's altered has some sort of traumatic injury until proven otherwise. And you'll have to use your agency guidelines and your best judgment on whether or not you put everyone on C-spine and stuff like that. That has changed for the most part. We don't C-spine every single person, but just be aware you have that diabetic who fell down the stairs. So you're there for an altered mental status stair fall, and you find them at the bottom of the stairs. You always got to wonder what caused them to fall. Did they trip? Did they get lightheaded? Did they have a cardiac issue? Did they have a stroke? Did they have low blood sugar? So don't get distracted by things like trauma. You want to know what led up to that trauma. Always determine nature of illness or mechanism of injury. So with diabetes, and here we're just going to continue with our nature of illness. You get that general impression. Are they fully unconscious? Are they altered? Where are they at? Do they have a gag reflex? Can they follow basic commands? So they might be altered, but if you give them a cup, and will they swallow water or juice? If you put some oral glucose in the side of their gum line, will it absorb? Can they swallow it without aspiration? Look for adequate breathing. If they're fully unconscious, we have that airway. Is the airway open? Have they vomited? Did they have a seizure? So is there anything in that airway? Can we drop an OPA in them? Because if they're fully unconscious as an EMT, unless you're able to use a glucagon injection or a glucagon nasal spray, there's not much you can do to raise this low blood sugar. So you need to oxygenate, and then it's going to be a rapid transport. All right, with the hyperglycemic, you have this Kussmaul breathing. Again, it's a very snoring respirations. Some people are able to tell the sweet, fruity smell of the ketones. Not everyone is able to do that. Test questions, they do talk about Kussmaul. Remember, it's hyperglycemic. Shallow or normal respirations, rapid respirations will be hypoglycemic. Both severely hyperglycemic and hypoglycemics, though, will have altered mental status. And if you don't have a glucometer to figure it out, we're always going to treat with glucose. So manage your airway and breathing. Check the skin. And again, skin coloring is not always going to be accurate. If they're in a house with a swamp cooler and it's monsoon season, they might be diaphoretic even though they're hyperglycemic. So just be aware for test questions what skin would be like in a perfect world for someone who's hyperglycemic versus hypoglycemic, but it's not always the case. Transport decision, altered mental status, you're going to want to transport. Again, depending on what you're allowed to do within your scope of practice, you may stay and play. If you're able to treat that low blood sugar on scene and get the blood sugar to normal, you might be able to do that treat and release. If they're totally unconscious, unresponsive, as an EMT, you're going to have to transport unless there's a medic that's going to arrive soon. History taking, we have family members, look for clues, look for medicines. Again, the big oral medications that you see are glyburide and metformin. There are some more on the market right now. It changes on a pretty regular basis. So try to keep up to date on those medicines that are available. I think Januvia is a new one that's out there right now. If the patient is able to answer questions or family members, you want to do that sample history, find out what medicines they're taking. In this case, obviously, we're looking for those diabetic medicines, the insulin, Humalog, etc. Talked about the sample history, things that you specifically want to know. When did they eat? Any exercise they may have done? Do they have an insulin pump or any other sort of devices related to their diabetes? Any nausea or vomiting or diarrhea that might cause them to become more dehydrated than normal. Your secondary assessment, if they're head to toe, if they're unresponsive, you're going to do a pretty detailed head to toe because the patient's not able to answer questions for you. You're going to look for those signs and symptoms related to a diabetic emergency. Very often, these are similar to things that you might see in an opiate overdose or a cardiac issue. So if they're unconscious, you learn how to rule out diabetic versus cardiac versus neurologic versus toxicological. You can't always do that without certain blood work. So again, you're treating those signs and symptoms. If they're not breathing well, put them on oxygen. If their respirations are too low, you bag them. Check that pulse. If the pulse is adequate for perfusion, you move on. If it's inadequate and it's poor perfusion and it's a pulse of like 30, 40, then you're doing compressions. So you're going to work your way through treating the signs and symptoms, and through your questioning, through the scene size up, through information you can gather, you hopefully can narrow down to, is this a diabetic issue, a stroke issue, and so on. You have your Glasgow Coma Scale. You want to assess if they're totally unconscious, unresponsive. Are they an 8? Are they a 3? Are they a 12? It's important if family members ask, what's their normal? If someone has Alzheimer's, you might not be able to get a good glucose, a Glasgow Coma Scale. Use that glucometer if available and protocols allow. Based on that score on the glucometer, you can hopefully determine is this a hyper or hypo glycemic emergency, and then you treat accordingly. And again, for EMTs, not much you're going to be able to do for a hyperglycemic emergency, but a hypoglycemic is definitely something that you can treat and return that patient to a normal. You want to reassess. If I have that patient who's altered and I'm able to give them food, sugary drinks, I want to recheck their sugar every 10 to 15 minutes on scene. And once it gets back to normal, we can have them sign the refusal because I want to keep track of how fast their sugar is rising. You want to take, so you have that initial baseline sugar, feed them, give about 15 minutes for that food to circulate through the digestive system into the blood. Keep feeding them, check it again, 15 minutes, 30 minutes, and so on. If they're totally unconscious, unresponsive, again, you're just transporting rapid transport to the hospital or until rendezvous with a medic unit if possible or if necessary. Remember, anyone who has an altered mental status, especially if they're fully unconscious, you have to worry about airway. If they start to aspirate, if they start to vomit, you don't want to have aspiration. So just make sure you're ready to suction if needed or to roll the patient on their side to clear their airway. And again, some jurisdictions let medics or let EMTs start IVs and may let them give intramuscular or intranasal glucagon. But Right now, that is not within the national curriculum, but that's probably going to change if, as the nasal spray version of glucagon becomes more and more common. When in doubt, contact medical control. You can help a family member give glucagon by explaining how to give it, but you are not able to give it. All right, so again, continue to reassess signs and symptoms. If you're not able to check glucose levels, you're still taking care of airway, breathing, circulation. If you put them on that non-rebreather and they start to wake up, well, maybe it's not a glucose issue. Why were they going hypoxic? So check the blood oxygen level, and when you're able to check the glucose levels. Here we have that coordinate communication and documentation. This would be that treat and release. Different agencies have different protocols. It's pretty common now that if you do have someone who is treatable with their diabetes, that we don't waste everyone's time and money by taking them to the hospital when they don't need to. Just make sure you document how you found the patient, what you did with the patient, and what their blood sugar was when you left, and that you can confirm the patient is now conscious, awake, and oriented ×4, or at least to the return to their normal mental status, and that they are going to be able to continue to feed themselves with complex sugar like carbohydrates so their sugar doesn't drop again, and that they understand why their sugar dropped. So if they drop because they had a fever, you can't just leave them at home if they don't have a way to make sure that fever doesn't cause them to burn all their sugar again, and you're back again with a hypoglycemic emergency. Again, back to our emergency care for diabetic emergencies. As I mentioned, we carry oral glucose. Some people might just have tubes of cake frosting in their purse. You can buy glucose tablets. These gels are rapidly dissolving or rapidly chewable. They're easy to chew tablets, or they're tablets that can dissolve. You can get liquid formulation. This is what we're going to give to anyone who we believe is having a diabetic issue. Again, regardless of whether or not it's high or low, if we can't measure it with a glucometer, we're going to give every diabetic with an altered mental status sugar. When do we not give oral glucose? Is that they don't have that gag reflex. They're not conscious enough to swallow properly. But again, even if they're altered, depending on their level of altered mental status, you might be able to squirt some of that gel right here in the cheek, between the cheek and the gum, and rub it in. And you might be able to have them absorb enough sugar through the oral membranes that they wake up a little bit more, where they can swallow a sugary drink. And then once they get that sugary drink in them, wake up a little bit more so they can actually eat something that will raise their sugar to their normal level. Anytime we're putting our fingers in near someone's mouth, obviously we're wearing gloves. And you want to reassess frequently the effects of that oral glucose. The presentations of hypoglycemia. Again, for EMTs, there's really no difference in how we treat hypoglycemia and hyperglycemia. So again, issues with hypoglycemia, seizure, coma, death. Rapid onset. Just remember, hypoglycemia tends to be rapid onset, and you can end up, like I said, you end up with a seizure and you go into a coma and die, and that can happen very quickly. You always want to rule out other conditions. You know, you have these multiple medical issues. They're diabetic who also does opiates. So in that case, you're giving them glucose and you're going to give them Narcan. So these are all things that you're going to look out for. You don't want to mistake any sort of diabetic emergency for drug abuse or intoxication. As I mentioned earlier, the patient with diabetes confined by the police is at risk. They think the person's drunk, but they're actually low blood sugar. So when you get called out, look for the identification bracelets, look in their wallet, look around for signs of the fact that they might be diabetic, check their blood sugar. They still might be liable for some criminal issues if they're driving with this medical issue. But again, we want to treat that diabetic emergency before they get taken to jail. and most of the time the police will have them treated and taken to the hospital. Again, with anyone who goes unconscious, whether or not it's hyper or hypoglycemia, you can lose that gag reflex. So you're laying on your back. The tongue can obstruct the airway, so you hear that snoring respirations. As they vomit, they can't protect their airway. So be ready to turn the patient on their side. Be ready to suction the patient. We want this patient to lie in the left lateral recumbent position or the recovery position while we're transporting them. All right, we're going to talk about blood emergencies now, hematologic emergencies. So this is the study of blood-related diseases. 3 types that we're going to talk about would be your sickle cell anemia, sickle cell disease, hemophilia, and thrombophilia. So we know your blood is made up of 4 major components. Your red blood cells contain hemoglobin that carries oxygen throughout the body. Your white blood cells fight infection, your platelets form clot formations, and your plasma is the liquid in which the red blood cells, the white blood cells, and the platelets travel around in. And your red blood cells are donut shaped. So sickle cell disease, it affects the red blood cells. Instead of those blood cells being circular, they're shaped like a sickle. It's common in people of African, Caribbean, and South American ancestry. Basically what happens is due to the misshapen red blood cells, they get blockages known as vaso-occlusive blockages in the joints. And this can result in severe pain and long-term hypoxia to organs, hypoxia to wherever that blockage is leading to, and organ damage. What you tend to see in the EMS field would be someone calling because they're having a sickle cell crisis and they're in a massive 10 out of 10 pain due to the sickle cell disease. So what you usually ask these patients, they know their sickle cell, they've had these types of crises before. It's important to get that history, and they will usually tell you, I have sickle cell disease and I'm having this crisis. And it's definitely a pain management issue. As an EMT, there's not much you can do for someone in sickle cell crisis. So these are some complications that you're going to see due to sickle cell: anemia, gallstones, jaundice, which is yellowing of the skin, liver dysfunction, and then vascular occlusion causing ischemia, which is death of tissue due to lack of oxygen. All right, very painful, can be potentially life-threatening. These people, this is a legitimate medical emergency. It's a chronic disease in which you have these flare-ups and they have to go get some pain management. They can get put on some medication at the hospital. You have hemophilia, which is a clotting disorder. These people are unable to form clots if they have some sort of laceration or abrasion or anything that will cause bleeding. They can basically bleed enough to send them into hypovolemic shock due to their body's inability to create normal blood clots. It's not on, many of these patients have to go to the ER on a regular basis for blood transfusions. This can become a very life-threatening disease. If you have a patient in a car accident who's a hemophiliac, they need to go to the hospital because we don't know what type of bleeding might be occurring internally. Thrombophilia, this is the disorder of the body's ability to maintain smooth flow of blood through the venous and arterial system. They keep creating clots. So if these clots travel to the brain or to the lungs, the heart, you can have life-threatening situations. So you can have a stroke, you go into respiratory arrest or cardiac arrest. Many of these people are taking blood thinners on a regular basis. They can develop DVTs, deep vein thrombosis, which if they break loose will travel up to the heart or to the lungs, causing immediate death for the most part. So you're going to look for these blood thinning medications, most basic one being aspirin, other things like warfarin, heparin shots. These are all things that somebody might have if they have this disease, they might have little screens inserted into their major blood vessels that are designed to catch clots before they get into any called any life-threatening injuries. They would be wearing compression socks, and that keeps the blood from pooling in their lower extremities and to keep help keep those clots from forming. So you're going to look for things like anticoagulation therapy, those blood thinners. You want to know, have you had DVTs before? So you have that person who has a warm pain in one leg. If you feel for that DVT in that calf muscle, you put your hand on it. Does it feel warm? Is it painful when you push on it? Those are signs of DVTs. For your normal person, have they been sitting down? Have they traveled in an airplane? Things of that nature makes it more likely that you might have a DVT. And again, if that DVT can travel, it breaks loose, it can travel to the lung, called a pulmonary embolism, and cause death. With these people with blood disorders, again, you're doing your basic scene size up, BSI scene safety, the nature of illness. Many of them are going to be conscious, awake, and oriented, assuming they haven't thrown a clot that went to their brain. They can tell you what's going on. As always, we're wearing our gloves and eye protection. Considered ALS. For most of these patients, other than giving them an IV and some pain management, if it's a sickle cell crisis, there's not much even medics will be able to do. You do your primary assessments, your generalized, is there any life-threatening bleeding, that hemophilia, they might be bleeding a lot more profusely than someone else from a similar type of injury. So take care of that bleeding as fast as possible, but understanding that direct pressure is probably not going to stop bleeding with someone with hemophilia because they're not able to form clots on their own. So make sure that airway is open, treat for shock, give them high flow oxygen. All right, again, with hemophilia, you're going to see the increased heart rate due to pain. With sickle cell, you're going to have that increased heart rate. They're in severe pain. Hemophilia, you're looking at hypovolemia if they're bleeding significantly, which is also going to cause an increased heart rate. Be signs for hypoxia because they don't have the blood cells to transport oxygen because they're bleeding out. So some EDs are better equipped to deal with sickle cell crisis or hemophilia. Just make sure you transport to the appropriate ED. And in these cases, all of these patients need to be transported. If you think someone has a DVT, if they're having a sickle cell crisis, if they're having, they're bleeding and their bleeding's not being controlled and they're a hemophiliac, you need to take them to the emergency department. We do our sample history with all our patients. Again, signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, last menstrual cycle, events leading up to it. Again, these are chronic illnesses. The patients know what's going on unless it's a newly developed issue. Hemophiliacs know they're hemophiliacs when they're young. Sickle cell, all of this is determined when they're younger. The clot developing disease might not develop until later in life, but that person won't usually know unless it's their first clot that they develop clots and that they're on some sort of blood thinner. Some other specific questions: is the pain isolated to a single location? Is it warm to the touch? Is there swelling? Are they having visual disturbances, nausea, vomiting, and abdominal cramping? We talked about the sample history before. Is this the first time they've had a sickle cell crisis? Is this the first time they've had a DVT or a blood clot? Is this what it felt like when you had your last blood clot? How did it resolve itself? For sickle cell, did you have to go to the ER? Did they give you pain medications? For the hemophiliac, did they give you a blood transfusion? For the person developing clots, did they put you on heparin or some other blood thinners in the hospital to dissolve that clot? You do your head to toe. With sickle cell, you're definitely going to focus on the joints, which is where those buildup of sickle cells occur. You do your AFPU, you do your LOC, get your complete set of vital signs. Expect someone in severe pain to have an increased respiration and increased pulse rate, but you still expect them to have a normal blood pressure. But if their blood pressure is extremely low and they're hemophilic, they have hemophilia, then you're thinking that there's some sort of internal bleeding that you might not be able to see with your head to toe, somewhere going in the abdominal or thoracic cavity. You want to reassess frequently, again, based on the patient's presentation and the vitals. It's 5 minutes if they're unstable, every 15 minutes if they're stable. We're always going to treat these patients for shock. So you're going to keep them, laying them down, keep them in that position of comfort, give them high flow oxygen, keep them warm, and transport. For the most part, as I said, even as paramedics, there's not much we can do in the field for these patients. So we're providing supportive care, treating the signs and symptoms, making sure we take care of the ABCs, transport them in that position that's most comfortable for them. All right, there's lots of review questions for this chapter. Please make sure you go over those questions, and when we go over this chapter in class, if you have any questions about any of the review questions as part of this PowerPoint or part of your quizzes, ask them and we can discuss those. Thank you.